Welcome to the Psychosocial Oncology Training Academy. I'm here today to present to you on breast cancer diagnosis and treatments. Funding for POTA has generously been provided by the Women's Breast Health Fund and Community Foundation of Greater Birmingham. My name is Gabrielle Rocque, and I'm an associate professor of medicine in the divisions of hematology and oncology, as well as gerontology, geriatrics, and palliative care. I'm a breast medical oncologist with research interests in quality of healthcare delivery and with an emphasis on shared decision-making and supportive care services to patients. I have no conflict of interests. Today, I'm going to talk to you about how breast cancer is diagnosed. I'm going to help you identify the most common types of breast cancer treatment and understand how treatments are chosen based off characteristics of breast cancer. Breast cancer is the leading cause of death for women in the United States. So many of you will wonder, how do I screen for breast cancer? Breast cancer is screened for using mammograms. Mammography should start for women age 40 to 44, and they have the choice to start an annual mammogram if they wish to do so. And this is really shared decision-making between the patient and their provider. Women age 45 to 54 should get mammograms every year, and women 55 and older may switch to mammograms every 2 years or continue screening yearly. Screening should continue as long as a woman is in good health and expected to live for at least 10 more years. And all women should be familiar with the known benefits, limitations, and potential harms linked to breast cancer screening as recommended by the American Cancer Society. In addition to this, anyone with a breast mass, regardless of age, should receive an evaluation with a mammogram. So who's above average risk? The recommendations that I provided on the previous slide showed those that are at average risk. But women who have genetic mutations, such as a BRCA mutation or any other breast cancer-associated mutation, as well as their untested family members, would be considered at increased risk and should have earlier screening. In addition, other women who have a greater than 20% lifetime risk, based on models that help predict risk using family history and other characteristics, should also be in a different screening category, as should those women who have a history of radiation, particularly mantle radiation to the breast, or other cancer syndromes. Ultimately, people with a family history of breast or ovarian cancer should talk to their doctors about their personal screening plan. When we diagnose breast cancer, we think about several different factors. First, we consider the tumor size and how big that tumor is in the breast. We also consider whether that breast cancer has spread to lymph nodes or other distant organs. When thinking about the size and spread, stage 1 through 3 are considered early stage breast cancers, and those include individuals who have not had any cancer spread to any distant organs outside of the lymph nodes. In contrast, those who have stage 4 or a recurrent breast cancer are considered a late stage breast cancer and may have involvement of organs such as the bones, lungs, liver, brain, etc. We offer several types of treatment for breast cancer. The mainstays include surgery, radiation, and medical therapies, which can include chemotherapy, targeted therapy, hormonal therapy, or immunotherapy. When we're choosing treatments, we take multiple things into account, including the stage of the cancer, their receptor status, particularly their estrogen, progesterone, HER2, and more recently PD-L1 status, as well as the toxicity profile of the treatments that we're offering. It's important to consider patient characteristics and preferences, particularly in places where there are multiple treatment options with varying intensity. And finally, I cannot forget the importance of clinical trials and the availability of those trials that we can offer to our patients. When thinking about the order of treatments for early stage breast cancer, we typically choose either a neoadjuvant approach, in which the chemotherapy is given before surgery, or an adjuvant approach, in which case the surgery is done first, followed by chemotherapy. After the surgery and chemotherapy are complete, if the patient is going to have radiation, that would traditionally come next, followed by the endocrine or hormonal therapy that they're likely to be on for several years if they have a hormone-sensitive breast cancer. When thinking about surgery, we use several different types of procedures. A lumpectomy is a smaller surgery in which only the tumor is removed. In contrast, a mastectomy removes the entire breast tissue. We also have a lymph node evaluation. A sentinel lymph node evaluation looks specifically at the first lymph nodes that the cancer would travel to, and potentially an axillary dissection, which includes removal of all of the lymph nodes. In terms of the medical therapy for chemotherapy and targeted therapies, for early stage disease, we usually are giving chemotherapy at a frequency between weekly and every 3 weeks. Patients have their nadir, or lowest point of their blood counts, usually in the middle of that cycle. For some treatments with chemotherapy, we use growth factor to help support those blood cells to make sure that they're sufficient to continue treatment. And that really helps us keep patients on target. In this setting of early stage breast cancer, we have a higher tolerance for side effects due to the potential for cure. In terms of hormone therapy, this is given to all estrogen and progesterone positive tumors and is very important. This allows for approximately a 50% risk reduction in that patient's risk of recurrence. And it's very important to take all doses and emphasize adherence. Patients will usually be on this for a minimum of 5 years, with many of them extending up to 10 years for additional benefit. For radiation, this typically lasts 4 to 6 weeks, although this can depend varying on the plan, and different programs can be offered to specific patients. This is given for almost all lumpectomies and some mastectomies for larger tumors or more involved lymph nodes. This can overlap with targeted and hormonal therapies, but is usually done following chemotherapy. For metastatic breast cancer, this is a different course of treatment. In this situation, we traditionally provide medical therapy until progression, followed by subsequent rounds of additional medical therapy. We often try to use the better tolerated treatments early on, anticipating that patients may be on these therapies for some time, and then less tolerated treatments and more aggressive treatment as the cancer progresses and becomes more resistant to our early treatments. We also use radiation or surgery to manage specific problems, but the mainstay of treatment remains medical therapy.
Hi, I'm Claire Rummage, and I'm a clinical oncology pharmacist at the Kirkland Clinic at UAB Hospital. I have nothing to disclose, and here are my objectives for today. Breast cancer treatment can include intravenous therapy, oral therapy, or even injections, or even a combination of the three. Therapies can range from traditional chemotherapy to more targeted therapies. Endocrine therapy is the backbone for hormone receptor positive breast cancer and can include anti-estrogens like tamoxifen, aromatase inhibitors like letrozole, which may or may not require co-administration of ovarian suppression like goserelin. Tamoxifen is one of the most common anti-estrogens used. A key thing to remember with tamoxifen is the significant drug interactions with strong CYP2D6 inhibitors like fluoxetine and paroxetine. So our go-to antidepressants with patients on tamoxifen are venlafaxine, citalopram, or escitalopram. The most common side effect of aromatase inhibitors are arthralgias and hot flashes. Ovarian suppression can cause menopausal symptoms, and there are some data to show that SNRIs, gabapentin, clonidine, and oxybutynin can help for hot flashes. If females are having vaginal atrophy, it's important to educate patients to use non-hormonal treatments like moisturizers and lubricants. Oral HER2-directed therapies include neratinib, tucatinib, and lapatinib, all of which are tyrosine kinase inhibitors and are known to cause diarrhea. Note that neratinib has significant drug interactions with antacids. IV and subcutaneous HER2-targeted therapies are available as well. Cardiotoxicity is a well-recognized adverse effect associated with these HER2 therapies. There is a new subcutaneous trastuzumab-pertuzumab combination called Phesgo. Margetuximab is a newly approved HER2-targeted therapy also. Aldotrastuzumab emtansine and famtrastuzumab deruxtecan are both HER2 therapies, but they are antibody-drug conjugates. An antibody-drug conjugate is an antibody bound to a cytotoxic payload through a chemical linker that is directed towards a targeted antigen expressed on the cancer cell surface. The mechanism reduces systemic exposure and therefore toxicity, but because of the cytotoxic payload, there is a class effect of bone marrow suppression. The traditional cytotoxic chemotherapy used in breast cancer include alkylating agents like platinums and cyclophosphamide, as well as anthracyclines such as doxorubicin and liposomal doxorubicin. Nephrotoxicity is a dose-limiting side effect for cisplatin, while myelosuppression is a common side effect for carboplatin. Cyclophosphamide can cause irritation of the bladder walls, leading to blood in the urine. However, doxorubicin, which is usually given in combination with cyclophosphamide, can cause red-colored urine as well. Dexrazoxane can be given for cardiotoxicity caused by doxorubicin. Antimetabolites and microtubule inhibitors are also traditional chemotherapy classes used in breast cancer. Fluorouracil and its oral prodrug capecitabine are known to cause hand and foot syndrome. Methotrexate can have some significant drug interactions with common medications, including NSAIDs, proton pump inhibitors, folic acid, and penicillins. Microtubule inhibitors like taxanes can cause hair loss, peripheral neuropathy, as well as swelling and nail changes. Transitioning to oral targeted therapy like CDK4/6 inhibitors, mTOR inhibitors, and PIK3CA inhibitors are all indicated for hormone receptor positive, HER2 negative advanced breast cancer. Here are some of the key differences in the three CDK4/6 inhibitors. Note that abemaciclib is the only CDK4/6 inhibitor with continuous dosing. With everolimus, I would recommend prescribing dexamethasone mouth rinse to help prevent mouth sores, per the Swiss trial. Finally, hyperglycemia, rash, and diarrhea are three very common side effects with alpelisib. The last targeted therapies available for breast cancer patients include PARP inhibitors, NTRK inhibitors, and immunotherapy. All of these require appropriate genetic testing to determine if they can be used. As we have discussed, there is a wide variety of breast cancer therapies, and I hope this continues to grow. Counseling our patients on their therapy is so important no matter the formulation because they all have potential side effects. My favorite patient education websites are IV chemo ed sheets and oral chemo ed sheets that are available and free to everyone. The education points are very reader-friendly, as you can see on the example shown. The takeaway points from today are that breast cancer treatments are ever evolving and are becoming more specific with targeted therapy. Oral therapy can be just as toxic as IV therapy. And finally, patient education is key. Here are the references from today.
Thank you for joining us for the Psycho-Oncology Training Academy bite-sized videos. My name is Dr. Margaret Liang, and I am an assistant professor in the Division of Gynecologic Oncology at University of Alabama at Birmingham. Today, I'll be talking to you about the topic of financial toxicity. I have no disclosures. So at the completion of this module, we hope that participants will be able to 1, define financial toxicity, 2, recognize sources of financial burden on cancer patients, 3, identify the 3 domains of financial toxicity, and 4, apply strategies to address patients' financial needs. So first, I wanted to describe what is financial toxicity. As we all know, patients are routinely counseled on the toxicities or side effects of treatment. This can include anything from rash, low blood counts, neuropathy, nausea, vomiting, hair loss, or fatigue. But now we've come to know that an additional potential side effect of treatment is the costs that are associated with cancer care. And the term that's been coined to describe this is financial toxicity. So as an example, if we had a newly diagnosed patient with breast cancer who is a single mother, she may undergo workup and treatment for her breast cancer, but suddenly be unable to work due to the side effects or the time required to go to her treatments. As a result of this, over time, she may have no money to pay for her bills or to take care of childcare while she's at treatments. In general, we know that financial toxicity can really impact one's overall well-being. So one of the purposes of today's talk is to talk about how to make patients and providers more comfortable discussing the importance of finances, because we know that there are a lot of emotional issues that can surround this sensitive topic. So certainly we know that it's important to develop rapport with the patient. So this may not be the first thing that we'll address in clinical practice, as we know that we have to build trust with the patient and be sensitive to their needs. In addition, we really want to make sure that patients feel safe and assure that they feel that this information is going to be confidential and kept private. In addition, it can be helpful to really normalize talking about costs, so making it a routine part of our clinical care encounters. In addition, it's important to talk to patients about the fact that this may be an ongoing stress during treatment, and we know that this is on top of the stress that they're already feeling with their cancer diagnosis. Finally, if we as providers and care team members are going to talk to patients about their costs of care, we really want to feel prepared that there are some resources available that we can bring up to them so that we don't feel that there's nothing to offer the patients once they disclose their needs to us. Finally, it's really important to make sure that the patient knows that we're on the same team and really humanizing the financial care as part of their comprehensive care. So there are different sources of financial burden on cancer patients that we should all be aware of. So I like to categorize these in two ways. So the first is direct costs. So this is anything that has to do with monetary costs. So within this, there can be medical costs, which include premiums, copays, coinsurance, medications, and medical supplies. And there can also be non-medical costs, which are still essential for patients to adhere to their treatment plan. So this can include things like transportation, parking, and lodging. Next, the big category is indirect costs. So I think of this as the time that patients are expected to spend adhering to their care. So this can include loss of work or income, like we described in that patient scenario, the need for other people to participate in childcare needs, and also caregivers who patients often heavily rely on for things like transportation or care when they're feeling poorly due to their treatment side effects. So in the literature, there have been about 3 domains of financial toxicity have been described, and this tries to describe the downstream effects that financial toxicity has on patients. So you can see the 3 here. So there's material conditions, psychological response, and coping behaviors. So we've already talked a little bit about material conditions. So this can include out-of-pocket costs, missed work, reduced or lost income, medical debt, or even bankruptcy in the most severe form. But we also know that this can have really psychological impact on patients. So patients have described feeling distress or anxiety related to the burden of finances that come along with their cancer diagnosis, fear about whether or not they'll get the same treatment if they aren't able to pay for it, isolation, and feeling like a burden to their family. So these are a really important part of financial toxicity also for us to address as a care team. Finally, there can actually also be downstream clinical outcome impact. So this includes patients potentially delaying or missing medical visits due to the cost of care, or not taking their medications as prescribed. So either splitting pills or not filling their refills as instructed. So now we really want to focus on what are strategies for us to address financial toxicity. So here I've put on a high level the different levels where we can intervene to help patients address financial toxicity. So on the patient level, we can make patients feel comfortable discussing issues related to their cost of care. At a provider level, we can screen for financial distress, which I'll talk a little bit about in the next few slides. We can openly discuss cost of care and normalize it as part of routine medical care and cancer care. And we can have the skills to refer patients to available financial assistance services or other individuals who can provide financial assistance to patients. On a health system level, certainly there's room to improve cost transparency for patients and provide financial assistance services, which is also often termed financial navigation. And finally, on a health policy level, restructuring insurance plan cost sharing would certainly decrease the burden of financial costs to patients who are undergoing cancer care. So what can providers do? So the first thing is we can really make financial toxicity a routine part of clinical assessment. So one way to do this is to add distress screening into the routine office workflow. And also, again, feeling comfortable bringing up costs as a routine part of care. So here on the right, I've shown an example of a distress screening tool. This is the National Comprehensive Cancer Network Distress Thermometer. So it's a widely used tool. It actually asks patients to fill out on a scale of 0 to 10 on the thermometer their level of distress on that day that they're being screened. And then beyond that, there's a problem list that shows a list of practical problems, family problems, emotional and physical problems, and spiritual problems that the patients may be having to help prompt a conversation and help us to find resources in order to address these needs that patients are facing. The next thing we can do is to select high-value treatment plans. So in general, we know that if we follow evidence-based pathways, we can decrease overall healthcare costs, which downstream will decrease the out-of-pocket costs that patients experience. So again, trying to avoid unnecessary testing or imaging, as an example, if it's not evidence-based. Finally, some simple things that we can consider is considering if there are cheaper alternatives to the medications that we might be prescribing. So a common issue that we see is that depending on the pharmaceutical tier that a medication is on, if we're able to pick an alternative that might be on a lower tier, it may be cheaper. There also may be generic formulations. Drug discount programs are also available and can be checked for certain drugs, particularly those that have to do with supportive medications like anti-nausea, pain medications, et cetera. And also one other thing we can do to be cognizant about the time patients are spending on their cancer care is to really evaluate the frequency of visits and potentially incorporate telemedicine to decrease their indirect costs. Next, we can really all stay up to date on the point persons and resources that are available at our own health system. So this can include anyone from a social worker, financial counselor, navigator, pharmacist, or financial assistance programs within the community, locally, and/or nationally. So as you can imagine, patients can easily get overwhelmed with all the paperwork and hoops they need to jump through in order to apply for certain financial assistance programs. So it's really important that we have and are aware of what resources and options are available, and to have someone that we've identified on our care team who really knows and knows all this information and can provide this information to patients in a compassionate way. So a designated person might be like a financial counselor who knows the right resources and can instill hope in patients, and often take the willingness to walk the extra mile to identify resources for patients in a timely manner. In addition, we can also help patients tap into their social support networks. So another example of this is really to tap into support groups for patients and survivors who may have gone through similar issues. A lot of times patients have described that they find good tips and tricks and advice from other people who have walked in their shoes before. And certainly incorporating caregivers into this process can be really important, as patients themselves can be really overwhelmed, and this support person may actually be able to help them maneuver through and find the needed financial resources easier than the patient who may be overwhelmed. So we hope that you have some tools now that you can use to help patients navigate the financial burden that can go along with the cancer diagnosis and treatment. Here are some references.
Hello, I'm Dr. Smita Bhatia, and I will be, along with Dr. Landier, giving you a brief presentation on breast cancer survivorship. We have no conflicts of interest to disclose, and the learning objectives at the completion of this module, the participants will be able to discuss the rationale for providing long-term follow-up care for breast cancer survivors and identify the key components of breast cancer survivorship care, and explain the referral process for UAB's Next Steps Breast Cancer Survivorship Clinic. Now, why should we have a clinic devoted to breast cancer survivorship? Most people diagnosed with breast cancer today will become long-term survivors. This is because there are significant advances in diagnosis and treatment, and there's an increased expectation for high-quality survival. Indeed, Dr. Julia Rowland from the National Cancer Institute has made a very astute observation that being cancer-free is not the same as being free of cancer. Cancer survivorship is a distinct phase of cancer care. It includes psychosocial coping, surveillance, long-term follow-up, detection and management of long-term complications, also known as late effects, and then health promotion. The cancer survivorship care includes need for continuing follow-up. Survivors and healthcare providers need to be aware of those health risks, and then primary care providers may be and often are unfamiliar with the problems faced by cancer survivors. There are significant late effects that can develop after breast cancer treatment. These include fatigue and weight gain, neurologic complications including cognitive impairment, often known as chemo brain, and peripheral neuropathy, musculoskeletal and soft tissue involvement with osteoporosis and lymphedema, cardiopulmonary complications such that patients can develop heart failure and pulmonary toxicity, and then reproductive complications including infertility, premature menopause, and sexual dysfunction. And then, of course, the psychosocial complications including anxiety and depression, fatigue, and altered body image. These all place the patients at risk for late effects, and these differ for individual survivors depending on the treatment received by the patients and other host factors. And now I would like to turn the podium over to Dr. Wendy Landier, and she will describe the key components of cancer survivorship care. Dr. Landier?
Thank you, Dr. Bhatia. I'm Dr. Wendy Landier. In cancer survivorship care, we have three main key components. These include clinical care, psychosocial support, and education. At UAB, we have a specialized clinic for cancer survivors known as the Next Steps Breast Cancer Survivorship Clinic. We address all three components of care in our clinic, starting with clinical care. We use an anticipatory, risk-based approach to allow us to identify late effects that survivors may be at risk for based on the particular treatment that they received. This allows us early detection and management of late effects, as well as referral to subspecialists as needed. And the care is provided by a nurse practitioner specializing in survivorship care. The clinic also provides psychosocial support in the form of a dedicated social worker who provides evaluations and referrals to local resources as indicated. The clinic provides extensive education for survivors. The education is tailored and is focused on health promotion. It is specific to the therapy each survivor received and personalized to that individual survivor. This is an example of the guidebook that a survivor would be given in the clinic. The guidebook includes a personalized cancer treatment summary, which the nurse practitioner reviews with the patient, providing details about all the cancer treatment that that particular patient received, as well as a personalized survivorship care plan and personalized health education materials. In terms of referral, patients are eligible for the clinic if they have had a diagnosis of breast cancer, they are at least 12 months from diagnosis, they have completed all of their planned cancer therapy with the exception that they can still be receiving ongoing hormonal therapy. The referral process is straightforward. For clinicians affiliated with UAB, this can be an internal referral completed through the electronic medical record or impact, and through submission of an internal specialty referral for the breast cancer survivorship clinic. Patients can also self-refer to the program, and clinicians can provide direct referral if they are outside the UAB system by calling area code
638-2155. So finally, what can you as a clinician do to promote breast cancer survivorship? Well, first is to acknowledge survivorship as a distinct phase of cancer care. Next, it's important to recognize the unique needs of breast cancer survivors and to identify breast cancer survivors in your practice. And finally, to refer breast cancer survivors for specialized follow-up care. Thank you.
Hi, I'm Janita Holt, a volunteer and support coordinator with Forge Breast Cancer Survivor Center. In this presentation, you'll learn the following objectives. You'll learn to recognize the long-term effects of breast cancer diagnosis on the survivor and their loved ones. You'll be able to identify benefits of emotional support and resources for survivors and co-survivors, and you'll also be able to locate community support resources for survivors and their loved ones. There are lingering psychological, social, and spiritual effects. For the survivor, there are fears of relapse or metastatic breast cancer for the rest of their lives. Over 50% experience moderate to severe levels of fear. Over 70% of younger survivors under age 45 experience moderate to severe fears. Spouses also can experience mood disorders such as depression or anxiety, and there's also an effect on children who experience their mother's diagnosis. There have been positive effects of supportive services for breast cancer survivors. They benefit most from one-to-one relationships or supportive groups of trained peers who are also breast cancer survivors. Breast cancer survivors who participate in small groups are at lower risk of cancer recurrence, and there are 56% lower risk of dying from breast cancer. Supportive services for family members and caregivers can reduce their mood disorders, their anxieties, or their stress to provide better and longer care for their loved one. After all of the consuming momentum of active treatment for breast cancer ends, that's when survivors need their support the most. There's a saying that when the casserole stops, that's when it hits you. I have cancer. Now I'm going to turn over our presentation to our Executive Director, Lauren Roberts.
Forge Breast Cancer Survivor Center supports, empowers, and improves quality of life for breast cancer patients, survivors, and those who love them from the day of diagnosis through the rest of their lives. We were created in 2016 through a collaboration with the 4 Birmingham healthcare systems, UAB, Ascension St. Vincent's, Brookwood Baptist in Grandview, and the Community Foundation of Greater Birmingham. Our offices are located in Birmingham, and we serve central Birmingham area and beyond. With the closing of Susan G. Komen of North Central Alabama in 2020, Forge is now one of the sole organizations serving breast cancer patients, survivors, and co-survivors at the same scale that Komen was. Forge's services center around 5 main quality of life domains: psychological, physical, medical, social, and spiritual and cultural. All of our programs fall into one of these categories. Under social, we provide a home away from home. That includes a house where you can stop by before and after treatment to have a cup of coffee with someone else who's had breast cancer, coffee conversations, book clubs, walks around the neighborhood with Forge, a number of health and wellness classes, including yoga, meditation, beautiful lettering, just opportunities to get together with other breast cancer survivors and get to know someone else. Under spiritual and cultural, we offer meditation, yoga, mindful breathing, and we can refer you to a spiritual advisor to help you with any other needs you may have. In psychological, we provide free mental health counseling through a partnership that we have with Oasis Mental Health Counseling. We also match our clients one-on-one with another breast cancer survivor who's had their same diagnosis, so they can walk the journey alongside of them. To help with the physical needs of our clients, we provide a host of different resources. We provide knitted knockers, which are knitted prostheses that we can provide that are lighter and more comfortable for our clients than the ones they're provided by their physicians. We have mastectomy pillows, port pillows, lanyards to hold your drains in the shower, financial advisors to help with the expensive costs of a cancer diagnosis, grocery cards to help with nutrition, nutritional information and education, and health and wellness classes. To help with medical needs, we provide lift rides and gas cards to help get you to all of your medical appointments. Our mentors can attend medical appointments with you so that you're not alone when you're in the doctor's office. We have lymphedema exercises, health and wellness classes, and a number of tip sheets on our website. Now I'm going to turn it over to Janet Dees, our Client Services Coordinator.
As Lauren mentioned, my name is Janet Dees, and I am the Client Services Coordinator at Forge. I am the first person that gets to talk to our survivors, and I find it to be a real privilege. When our survivors call or when someone calls to refer someone to us and I call them back, I try to assess from just talking with them and from all of my years of doing oncology nursing to try to figure out what is it that these clients need that could help them the most. And as Lauren mentioned, we offer several things at Forge. We have the bags for new survivors, whether it's brand new, they've just been diagnosed, whether it's a second diagnosis. We also do the peer matches, where we take someone who we specially train, who is one of our volunteers, and match them with a new survivor to help them walk the walk. They've already been through the journey, and they can tell them things that as healthcare professionals we might not be able to share. We do the support groups. We do them in person and virtually and on Facebook. We actually offer a young breast cancer support group and a metastatic support group on site at the Forge House. We do the free professional mental health counseling with Oasis, as Lauren mentioned. And this is really important because sometimes our survivors don't want to talk to their loved ones about what they're going through because they don't want to burden them, and it gives them someone outside of their family and their close circle to do that with. We offer the lift rides and the gas cards. These are to help patients with whatever they may need to get them back and forth to medical appointments. Some of our survivors don't have someone to drive them. And so they can use the gas cards to ask a neighbor to do that, or we do provide the lift rides. The grocery cards are for nutrition, but they're also to help alleviate financial strain. If someone's having trouble paying their copays, maybe having a grocery card helps them then use that money to use for their copays. We do the group health and wellness classes. We do things from yoga and stretching to really fun things like gardening, arts, crafts, and providing things like Swedish weaving. We do tip sheets that we can give as hard copies to our survivors, or they're on our website. Some of the other things we can provide are some post-op supplies that help our mastectomy survivors, help just navigate that process a little better, and to those going through treatment for chemo or with radiation. We are proud to partner with other resources in Greater Birmingham. One of those is Brenda's Brown Bosom Buddies. And their goal is to serve women of color. They help provide transportation for breast cancer treatments. They provide some light housekeeping assistance. They also do financial assistance with mammograms. And they have a great scholarship assistance award that they do through the Birmingham Black Nurses Association. The Angel Squad, many of you may have heard of them. They are a long-standing volunteer group that works with families and patients out of the UAB Kirkland Clinic, and they provide hope, comfort, and compassionate care to those. One of the other ones that's newer that we've enjoyed working with is Pink Tops. They focus on early detection of breast cancer for women and men under 35. They offer overall breast health education, well-being, and support through advocacy awareness. They feel like all of us do that early detection is the key to winning the fight against breast cancer. We would love to help you with any of your patients. The best way to get a hold of us is to look on our website at forgeown.org. It has our phone numbers, our email. We would love for your patients to stop by our house. So we look forward to working with you to help these survivors.
Hi, I'm Gabrielle Rocque, and I'm a breast oncologist and associate professor of medicine at the University of Alabama at Birmingham.
And I'm Hennessy Williams. I'm an internal medicine physician at primary care with UAB.
We're excited to talk to you today about some common questions that come up in oncology and primary care. So, Dr. Williams, what do you think is the most common question that primary care doctors want to know about from oncologists?
So one situation that we see come up frequently on our screening mammogram results is a patient that is noted to have extremely dense breast tissue and that they might benefit from further imaging. How should we handle those patients?
That's a great question, and something that's been coming up and more often recently because of the new rules about discussing breast density in the mammography results. And so what we recommend in that case is that actually we move forward with a screening MRI, because that can better identify potential breast cancers, particularly for those women who have dense breasts, and it's more difficult to tell in those women if there is a breast cancer in the background of that additional density.
Oh, sure, okay.
Are there other questions that commonly come up related to screening?
Yes, could you speak a little bit more of just how we should take into account a patient's family history when we guide them towards their recommended screening?
Absolutely. So family history is a really important part of how we think about screening for breast cancer. So in general, when you have a first-degree relative, so a parent or a sibling that has a breast cancer, particularly at a young age, we start screening 10 years before that previous person's diagnosis of breast cancer.
Okay.
In addition, we really want to take a good family history to understand who in the family has had different cancers, particularly breast and ovarian cancer. And in families where there are multiple different people with cancer, we often will think about genetic testing and potentially high-risk screening programs. So we will do genetic testing and additionally MRI for those women who have high risk, particularly greater than 20% lifetime risk of breast cancer. And we do have a screening program at the University of Alabama at Birmingham that is specifically geared towards those younger women who have family histories and are at higher risk of breast cancer.
Great, that's super helpful. What about any other special populations that we should be aware of where we should order imaging outside of typical screening?
Mm-hmm. So that's another really important point. So our typical screening starts at 40 years old, but we do know that sometimes breast cancer does happen in women who are younger than 40. So as a general rule of thumb, for a woman really of any age that has a new palpable breast mass, something that they notice on exam, we recommend moving forward with imaging no matter how old they are, just to be certain that we're not dealing with a breast cancer diagnosis. Another group that's really important to consider are those women who are pregnant or who have recently been pregnant. And so if you do have a person who is potentially breastfeeding, we do see mastitis and other types of problems. But if there is a mass, it's important to make sure that those women, particularly those women who are breastfeeding, are referred for imaging and mammogram.
Great. So we should get imaging regardless of if they're pregnant or breastfeeding.
Absolutely. So those patients definitely should be referred.
Perfect. Okay. So what about once we move on to our patients who are actively being treated for breast cancer? Are there any specific symptoms that we as primary care should be looking out for?
Yes, so oftentimes patients who are undergoing treatment will call their primary care physicians instead of their oncologist when something comes up. So some of the symptoms that we should be concerned about are usually things that would be considered a sign of infection. So if you have a patient who's recently had chemotherapy, Usually it takes about 2 weeks for our common breast cancer chemotherapies to reach their nadir or their lowest point. So in that 1 to 2 week time period, if they have a fever or concerns for infection, we would be looking for neutropenic fever. So those are patients that really should be evaluated. And we usually think about screening labs, blood cultures, chest x-ray, and a urinalysis to look for potential sources of those fevers.
Okay, perfect. So many of our patients follow very closely with you all while they're undergoing treatment. Can you speak a little bit about how the transition should work when they complete treatment, transitioning from oncology to primary care, and what special things we should be doing for those patients?
So, as you mentioned, many patients are going to transition from their oncologist to their primary care physician. And that most often happens around 5 years for those patients that are not on treatment. For some patients that are still on hormone therapy, we will continue to follow them primarily in the oncology clinic for up to 10 years. But usually at that point, we are able to transition the patients. Now, ideally, those patients should come with a survivorship care plan that will help outline some of these recommendations. But some of the things that you would want to consider as a primary care physician are making sure that that patient has an annual mammogram and MRI, if appropriate or recommended, from the oncologist. Additionally, things to consider are bone density. So many of these patients will have had hormone therapies that will make them at risk for osteoporosis. So really ensuring that they're getting routine bone density checked. And then finally, as you are already doing in primary care, really encouraging a healthy weight and exercise and diet, as we know that that's important for their cardiovascular risk as well as their breast cancer.
Okay, great. That's helpful. What about maybe particular symptoms that we should be on the lookout for that might indicate perhaps a recurrence of the cancer?
That's an important point. So particularly as patients are getting further out from their breast cancer diagnosis, they are seeing primary care more often. And it's important to recognize that these patients can have recurrence. And so if a patient comes with a new symptom, for example, new back pain, that has been persistent and longer than you would expect for a usual ache or pain, or a cough that's lasted for longer than 4 to 6 weeks. Those are times at which we really want to think about imaging. So it's important in patients with a history of cancer to be mindful of new symptoms that are persistent and to go ahead and order those imaging either yourself or reach back out to the oncologist to see if perhaps that imaging would be indicated.
Sure. Okay, great. How about, could you speak a little bit about maybe some late effects of the chemotherapies that they might have received that we should be aware of?
Another important consideration is these late effects of chemotherapy. So in particular, some of the scary complications that we can have in breast cancer patients, particularly those who've received previous chemotherapy, one of them is heart failure. So thinking about if a patient comes in with new shortness of breath, with new leg swelling, or any other symptoms that might indicate a diagnosis of heart failure, being mindful that they are, particularly if they've had an anthracycline in the past, at greater risk of heart failure. Another issue that sometimes comes up, rare but serious complication, are secondary leukemias and myelodysplastic syndrome. And so really making sure that those patients, if they are feeling unwell, are getting a laboratory analysis, as complete blood counts, to look for potential bone marrow problems that, might lead us to a diagnosis of acute leukemia. And I think another important point is to have these patients be getting their routine labs. So most patients, I assume, following with primary care will get an annual lab, and that's totally appropriate for that to be done through primary care rather than their oncologist. But we do like to see their liver function and kidney function and routine labs checked once a year.
Okay, great. Well, thank you so much, Dr. Rocque. That was so helpful in helping us as primary care doctors be able to take care of these patients.
And thank you for all the great care you take care of our patients and this opportunity to talk to you today.
Great. Thank you.
Thank you.